I have this philosophy where patients aren't injured or broken. Technology's broken. Western medicine is based on treating symptoms. You got diabetes. You come in with your blood sugar. We treat labs and symptoms. Blood sugar's high. Give you insulin. Go home. Keep doing the same thing. We just pile you on with insulin. You come into the office. You have a 20-year history of smoking, and you got lung cancer. What's the cause of the lung cancer?
Smoking.
100%. See how easy you were able to answer that? Just like you were answering me the cause in lung cancer, I'm going to ask you, tell me how that ACL tear was caused.
Couldn't tell you.
Exactly. You see the difference? So if you don't know what caused it, how do you know how to treat it?
Welcome back to the Athelis Taking Back Healthcare podcast. Today, we are joined by one of our illustrious partners, Dr. Arthur J. Ting, orthopedic surgeon extraordinaire. Thank you for joining us today.
Oh, happy to be here.
Amazing. So just to get started, I mean, you're one of our most valued partners here. I would just love to kind of, get a background on your background and, how you ended up here today.
Okay. Well, one of the questions that I'm always asked is how do I get started in this? And back in I've been practicing for 40 years. So when I was first getting into medicine and how it happened was I'm the son of two immigrant parents. And back then you didn't have career days or anything like that. You kind of just were told to go to school. We want you to be a doctor someday. And so that's kind of led me into the healthcare field and pursuing medicine. There's really no passion or story that I have growing up. Just went through the process, pre-med undergrad, medical school, had a passion for sports. And so I felt like orthopedics would be the best field to go into. So that's what precipitated my pursuing orthopedics and sports medicine.
Amazing. And I understand you also do treat some sports stars, right? Some actual celebrities.
Yeah, through the years, I've had relationships with pro teams. I was the first team physician for the San Jose Sharks when they first came to San Jose. Did that for 20-some years. And so through my relationships with agents, other pro athletes, I still get referrals and still deal with a lot of the athletes at that level.
And so I'm curious about how you kind of even came upon Camure Athelis and kind of, what your journey with, our company and our technology has been like.
I've always been a fan of technology, especially in the Silicon Valley. I've got some relationships through what I do with some VCs in the area. So been constantly around it and always been I have this philosophy where patients aren't injured or broken. Technology's broken.
True.
So I've always gone to the engineers and said to them, hey, produce me a better implant. Get me a better way of fixing this. Because I know in their mindset is, tell us what the problem is, we'll solve it. So I've been really intrigued with how technology has evolved, especially being so close to Silicon Valley. And like I told you, I love walking into this place. Right. The whole aura of being in a place like this just fascinates me because it's so far away from what we do, being structured. I've always been fascinated by technology. So when Athelis came to us with new technology on how they could more efficiently and more accurately do our medical records, our billing, our front office, we were definitely I was definitely receptive.
Right. You're like, it's a clear need. Now let's see what we can do. So what did your operations look like before incorporating our technology, and what does it look like now?
Okay. So we first started with, we were going to change our EMR. Okay. Everybody has EMR. It's got to be Medicare approved. So we started EMR when it first came out and our contract ran out. So we started interviewing, and Brandon Haywood, my manager's very into the technology world. Okay, it was kind of like he enjoys doing it. Yeah. So anytime I get an employee that enjoys something and can benefit us at the same time, I'm all in with supporting that. So let him interview and go through all the processes with different companies. And he says, hey, there's this new company. It's right here in Mountain View. And we knew the rep who was selling it. We knew, God, I can't think of her name right now. But anyway, we knew the rep through another venue that she was doing. So she had an in to our office already. Right. So she was coming in, hey, it's a new startup. They're using AI. When I heard that, this was 2 or 3 years ago, I said, let's research this. And they were new to it also. Okay. And so they were a startup. We needed it. I looked at it, as I've told you, and I tell potential clients all the time that this is the worst it's going to be today. Okay. Because these people just keep going and growing. So that's where the relationship started.
Right. But it's interesting that you say, you heard AI in tech and your ears perked up. Folks in healthcare are pretty resistant to change in general. So why do you think you in particular were like, we have to jump on it while we can?
I don't think they're resistant to change. I think they're resistant to chaotic or unpredictable change.
Sure.
Okay. Because with all our restrictions, FDA, HIPAA, and that's only gotten worse over time. In my lifespan, I've seen it. They restrict us. So everybody's puts up a wall. But if you can demonstrate to them that this change is predictable, everybody wants predictable results. I mean, that's medicine too. Okay, that's medicine 101. If you can't get me a 90%, outcome, nobody's taking 50% in healthcare. Okay, I mean, that's a coin toss. Nobody's doing that. Okay, they want predictable outcomes. They want to see it first. So I'm more in the line of, if technology, and I believe in the technology, which I believed in. I mean, you cannot not believe in it. It's right in front of you every day. It's not change like I'm guessing, or it's not predictable. So I think, yes, there is a wall, definitely. And doctors are not, their mindset is stay with what works. Okay. As I put it, if you're not willing to walk in traffic, you're not going forward. Okay. So I'm a little bit more probably receptive when it comes to technology or office workflow or revenue cycle management stuff, collections. I'm all for that. If there's a better way, which turned out it was a better way.
Right. What's interesting, in the current, version of AI, one of our advisors, Eric Larson, he had an apt point where he said, in Web 2.0, the situation was the more you can specify a problem, you can automate it. But now with LLMs, the more you can, if you can verify something, then you can automate it. And so within the space of healthcare, the problem right there is revenue cycle management. And we found that we're able to, do that very effectively. And so I'm kind of curious to hear from your perspective and your practice, how our revenue cycle management platform has kind of changed things.
Okay. So the biggest problem in collections or revenue cycle management is either the partial payments or the non-payments. Okay. They all will collect what's sent in automatically. Okay. All of them. The biggest issue is going after the AR that's out there. Nobody wants to do that. In the past, your collector gets on the phone,
right,
tries to chase the person down. It's not happening. First and foremost, you're depending upon that person's willingness to do something that nobody likes doing.
Right. Are you saying the person who has to collect the AR or the person paying?
The person with collecting.
Right.
Okay.
Which for you has to be frustrating because you're like, it's money on the table.
Right. And then you're paying a percentage to your collection person what's already coming in. Okay. So that's my point. Okay. With AI, you don't have to deal with that person. And that AI likes doing it. That's their job. So they hunt down that they text every other day. They have a system of collection, automated, yes, automated, intelligent system. Okay. So you're no longer dealing with a person, and you can, that process gets done. And like I bring up, we've changed billing companies multiple times in my 40 years of practice. Okay. Multiple times trying to figure out, hey, this company's better. This company doesn't charge as much. Okay. And during the ramp up phase, you expect collections to drop. When we were dealing with Athelis in the first month, like I said, over 2 years ago, the collections for the first month during the ramp up increased our collections 60% of what it was. Unheard of. Absolutely unheard of. Okay. And like I said, that's the worst it was. Okay. It's only gotten better. They scrub out the insurances. I mean, everything's been better. Okay. As Camir, Athelis, Scribe, everything's gotten better.
Right.
As well.
So you just mentioned, the 60%, but you also were referring to AR. For the overall collections, do you remember the breakdown of like what was being impacted by your revenue the most? Like, was it AR? Was it the denials? Or where were you seeing the biggest uplift?
The denials dropped like 30%. It was a combination of everything, but 60% is a big number. Yeah. So they hit it with AR, recent billings, whatever you want to talk about, it went up. Okay. Our denials went down. Okay. So things were getting approved better. So from that standpoint, our office workflow was better. Right. And that's, if you're thinking of just business, it's the number one. Yeah. That's on the top of the list. Yeah. Top line metrics for sure.
That even like a caveman can understand. Revenue up, denials down.
Everybody's happy. That doesn't matter what else is going on in there. Right. But then we adopted the whole system, EMR, AI agent, front desk. We adopted the entire system.
Right.
So.
And so what has adopting that new system really meant for kind of the downstream effect of what really matters of like your patient care? How has that changed your relationships and interactions with your patients?
It's done nothing but helped it. We can put out letters now, get approvals. It's increased the efficiency, which has allowed us to do more with the same amount of, I would say, less personnel. Right. So anytime you can do more with less, that's a win. So I can't express how happy we are with it. So
that's incredible.
Yeah.
And what does it look like from the perspective of, like, let's say I was an MSO and I came to you and I said, tell me about how your business has been revolutionized by this. Like, how would you kind of pitch this to them?
Well, the most obvious pitch is when I was looking at, I get approached by private equity as a single practice, which in their world would be like a bolt-on. They want to acquire you, pay you a multiple of what the practice is worth. You continue to work for them, which I want to do. I want to continue working. But then they have a say in management. Okay. And then you've heard about them cutting costs and things like that. And so the only negative side of PE that I've been told is that they kind of control how you can practice.
Sure.
Okay. Otherwise, it's a big influx of money for you, especially somebody at my stage, which you would look for. The younger guys don't get any of that or anything, but I don't have any real partners either, so that wouldn't affect it. But I look at the efficiency, my revenue stream that happened once we started with Athelis, and I tell people all the time that was not my private equity move without selling it to anybody. Right. Okay, so from my standpoint, it's improved my revenue, which from an MSO standpoint, that's their bottom line. They want to flip it. They want to make money. So I would tell them, you present that to the person you're trying to acquire, and you automatically have increased their revenue without doing the other things that they try to look at. They look at potential for surgery centers, ancillary product to increase the productivity and revenue of the existing practice. We did it with what was going on there currently and increased revenue.
Right.
Okay. But moving on from that, it's also been a tool that we've used to isolate certain payers and do what we used to do when we encouraged fee-for-service volume.
Mm-hmm.
Okay. Instead, we've increased fee-for-service volume by specifically seeing what the payers pay for certain procedures. And Athelos has allowed us to isolate that in seconds.
Interesting. So what does that look like operationally? Are you saying that you will make sure to say, we're going to stack these patients on this day for this payer?
No. Okay. What it does is when we go for approval, insurance company approval, which dictates how you're getting paid these days, we'll have the payers, the insurance companies on a spreadsheet and see they reimburse PRP for X amount, 4,000, whereas another payer will reimburse for 300. Okay. So now instead of concentrating approvals for the $300 payer, we'll concentrate getting the approval for the payer that pays higher. Patients don't know, unfortunately, that's one of the biggest problems with healthcare is the inconsistencies of the payers. Okay, that's a product of the insurance companies, which, quite frankly, we can't control. Okay, but we can help utilize it in the best way to make it financially optimal through software technology. In a matter of seconds, we can look at that. Okay, so whereas that's something that would take you hours and hours of work to try to extract, getting your payer mix for what procedures. And that's just one example. So through our relationship using the software that Athelos provides us, we've been able to, Brandon, I got to give Brandon credit, who's able to extract this out to our advantage, to optimize both time and reimbursement. That's why, implementing the technology that Athelos affords us with is to me a private equity move without having to sell anything.
Right.
So if I'm talking to an MSO person or PE firm, I'm telling them the first thing you do is you get their technology and office technology up to speed.
Right.
You've already increased the value of it.
Right. And so when you're saying it's a PE move, it's because you're able to decrease your operational expenses, increase efficiency, and increase the revenue.
Increase revenue collections.
Yeah.
Yeah. And that's without using almost anything, just bringing in new technology.
Right.
Becoming more efficient. Yeah. Like I said, it's easier. In the old days, you got paid what you billed. So the fee for service volume was the business model.
Right.
Okay. It no longer is that because one company will reimburse you X dollars, another one will do it for another amount. And there's no consistency. The insurances, if you're willing to buy a certain health plan, they'll sell it to you. They got so many plans out there that no matter what it is,
and they're all abbreviated, you get confused.
They try. It's all over the board. It doesn't make any sense. It has nothing to do with what's proper. It's a problem with healthcare. It's being dictated by basically insurance,
There was a story you were telling me just before we started chatting here about a letter you got from an insurance adjuster. I was hoping you could tell that again here.
Yeah, so it was a pretty complex letter. Okay, the adjuster outlined a patient that we were trying to get a new body part on a certain claim. Okay, and I had x-rayed it pre-date of the new injury date that he says, so firefighter, hit his head on the truck, hurt his neck. Okay, but he had a previous claim where I x-rayed his neck. So there was a pre-existing part of this. Anyway, he wrote the letter. There was a lot of points in it. was very confusing. Very confusing. It's talked about different dates of injury associated with different claims. It was about 2 pages with all this stuff I thought he was trying to confuse me, to tell you the truth, the adjuster. And he was at the same time.
What a surprise.
Yeah. And at the same time, he's trying to deny the claim. Okay. So I took the letter, downloaded it, and then I also put in 2 previous progress notes that had to deal with the previous symptoms and the previous claims, and said, please defend my actions with the previous injury as well as the current injury and answer the questions the adjuster is proposing. 5 seconds. We just put in the scribe, told the scribe what to do with it, and gave it. They organized it, separated out the claims, gave not only the how but the why. It was done. So it saved us time with that. Okay. I mean, no matter what we do these days, AI is involved. So people who say, oh, the lawyers will say you can't use AI, you've got to reveal that whenever you're doing something. I mean, we use AI for everything now. So I don't think you can. I mean, it's not replacing what I do, but it's definitely enhancing.
Right.
Okay. And I think that's the biggest part of how it's helped. It just saved me hours of trying to figure this out. And it's not really, this is when doctors say, hey, I just want to treat people. Okay. I hate this extra work that we have to do to get approval, to be able to treat somebody. This is the type of thing that's going to save you. So instead of embrace it, as opposed to say, oh, I don't even want to deal with this. This is going to help you get to that point where, like in the old days, everything got approved, and you could concentrate on treating. I no longer am looking at a computer the whole time, trying to fill in, the templates that we have to get approval for certain things. I can sit there, I can make eye contact with the patient the whole time, and the scribe is picking up what I'm saying and extracting and loading into the right template what we need to move on with the treatment. So it's helped us with that phenomenally.
Yeah, and to the point of you interacting with the assistant there, and you're trying to come out with another letter, you don't have to worry about being Thomas Jefferson creating the Declaration of Independence. You can be like, I want this, and then it gives you the ideal output, and it's as simple as that, really, right?
Yeah, and I have trouble articulating in a letter type thing. So my grammar in making charts, letters, and stuff like that is below par. So having somebody rescribe it and put it in very simple, being very articulate and doing that, it's made me look way better, So I no longer dictate. My op reports are all pre-templated. I put in what I need, and the scribe extracts it and prints out like op reports, medical necessity letters. I've told Brandon this, I want to get it to the point where I can put my surgery schedule in and all my op reports are done. I mean, he thinks that's a little bit too much, but I think that I'm getting closer to that.
Yeah.
So think about that. Right. You no longer have to dictate everything because the algorithms are there. You do something enough times, there's only certain paths to the algorithm that you can take.
So from like a patient's perspective, do you have any particular warming stories of, how you've been able to give care to a patient since your operations have changed?
Again, we try to do shadowing or mimicking technology in the sense that when you look at what the biggest advances have been, it's always something where you said, God, I wish I would have thought of that, like DoorDash or Zoom. These are things that are right in front of us. We just to execute it differently, boom, makes it extremely different, right? So let me tell you how we sort of apply that to my own practice. Okay. So we started looking at the most common thing I see in my office is an overuse injury. tendonitis, inflammation, hamstring strain, things we call self-inflicted. Nobody crashed, nobody tackled you, but you strained something, okay? So self-inflicted. Western medicine is based on treating symptoms. You got diabetes, you come in with your blood sugar. We treat labs and symptoms. Your blood sugar's high, give you insulin, go home. Keep doing the same thing, we just pile you on with insulin. We're not treating the root problem, which would be to diet, exercise, all the stuff that how you should be doing. Instead, we just treat you for the lab result. Extrapolate that to orthopedics. You strain your hamstring. You're a high-level high school athlete, okay? We rest you, go to physical therapy, okay? Ice, anti-inflammatories, stretch, go back, do the exact same thing. Strain your hamstring again. We're not treating the root cause. What's causing the strain? It's your mechanics. You're overstriding, you're fast twitch. Okay, it's a two-joint muscle. Can't do anything about being fast twitch or two-joint muscle. Fast twitch is a gift. Every pro athlete is fast twitch. That's what separates them. So that's genetics. We break down your mechanics. Your stride length is too much. The higher level the athlete, the more difficult it is to figure out what he's doing wrong. Take a guy like Kittle. It's overstriding. Fast twitch as hell. Hamstring. After a day's rest, coach is beside himself. Why did this happen? It's not because he's not hydrated. It's not because the trainer's not stretching him. Got to break down his mechanics, man. His center of mass, base of support. Famous race. Maurice Green, Michael Johnson. 200-meter Olympic trials, probably before your time, but most of...
Was this the asterisk run?
No, it wasn't. But my point is you had the two fastest guys in the world running the 200 meters. They're both Americans. These guys, the top two guys, make the Olympic team. Michael Johnson strains his hamstring in the middle of the turn. Maurice Green pulls his calf coming off. Neither one of the top two guys didn't even finish. My point is, you're telling me those guys didn't stretch right? They weren't hydrated? You got the best trainers, the best coaches. These are the two best guys in the world. Neither one of them finished the race. What you can say is that the minute where they did the injury, one was in the middle of the turn, the other one was towards the end of the race, they started overstriding. Just think of a little kid running 200 meters in his first race, 50 yards, an 8-year-old. His legs are all over the place. He's turning his head back and forth. His arms are going all over the place, right? No control. That's the problem. Not resting him, gunning it, suction cupping it, stretching it, resting. That's the root cause of the problem. So going back to technology, we have technology now, or one of my sons is developing it, where he puts joint vectors on the athlete and can determine his center of gravity with his base of support, demonstrating when he's overstriding or when he's doing the movement that predisposes him to injury. That's my point. We're using technology to help us. And like I said, the higher the level of the athlete, the more difficult it is to figure out exactly what he's doing. But I gave you two elite athletes, okay? So now what's happening, we train the healthy athletes in this way. We show them, because another example, if I was to ask you a question, if I was to say, okay, you come into the office, you have a 20-year history of smoking, and you got lung cancer. What's the cause of the lung cancer?
Smoking.
100%. See how easy you were able to answer that? Okay, now we talk about non-contact ACL tear. Okay, very common. 20 years ago, it wasn't that common, or actually 40 years ago when I first started practicing. It wasn't a household term. Now it is. Everybody knows what an ACL tear is, right? Just like you were answering me the cause in lung cancer, I'm going to ask you, tell me how that ACL tear was caused.
Couldn't tell you.
Exactly. You see the difference? So if you don't know what caused it, how do you know how to treat it? Has to do, the most common cause of a non-contact ACL is your center of gravity or center of mass is behind your base of support, meaning your body weight is behind your foot. You hyperextend your knee. So if you train a person to stay away from that, you can help prevent it. Like again, I said, if you don't know what caused it, how can you prevent it? So one of the things that when you ask about why people come to our office, it's usually a tertiary case. They've been elsewhere. They've torn their hamstring or things like that. We've tried to focus on the root cause of things as opposed to treat them, symptomatically, like the standard of care. We try to give them care that's different. Otherwise, why are you going to drive the Fremont? Okay, we got to do something different. So we've concentrated treatment and diagnosis on basically educating the athlete. Like it's pretty rewarding. You asked me about a case where it's come back when a 14-year-old girl says, I tore my ACL. My center of gravity was behind my foot when I landed, and I hyperextended my knee. She's telling me how she did it because she's been trained in our facility to know that, not to do that. Right. Yet she still did it. But this is a girl that's 14. Right. When I asked you how it was caused, you answered the lung cancer problem without any issue. But when I asked you about ACL, you couldn't tell me. And that's common. Right. I get a room of athletes. We preface the talk on mechanics with that example to make people aware. Yeah, how can I, if I don't know what caused it, how do I prevent it or treat it? They just don't know. Coaching hasn't changed. Okay, doctors know how to treat it. Coaches know the right mechanics, but they don't know the injury. You need an intersection between those two to get to the bottom of the most common ailments we see.
It also begs the question of how many athletes haven't reached their full potential, because Steph Curry early in his career had ankle issues. Then they pretty much retaught him how to walk, how to run, all that kind of stuff. And now he's Steph Curry as we know him today.
Right. Essentially same type of thing that we're saying. You got to treat the cause of why his ankle turns in or is unstable with certain movements, but exactly the same thing, except put in different ways. We're treating mechanics. That's probably the root cause of the majority of these things. And we're trying to develop this joint vector analysis where the athlete's going to be able to tell on his own what he's doing wrong and analyze his workouts, analyze what he's doing and what we think is the root cause of this.
So you've been willing to, pilot some of our technology and features that, were effectively not all the way fully baked. How do you decide when something is worth trying out?
Well, like I said, in the scribe portion of it, I would actually like to use AI more. Okay, because I think it can save me time and be more accurate. And like I said with the op reports, every time I come up with a thing, I tell Brandon, I say, hey, ask Athelis if they can help me with that. And tell them what my vision is. I always tell you that because, like I said, technology is broken. I'm not broken. I want technology to be able to take my surgery schedule and with certain key, using large language model or key verbiage, they can do the whole op report without me having to dictate the whole thing, and they can do it in a way better way. So I'm constantly trying to get more out of you guys.
Right.
Okay. For lack of a better term. So I'm more than willing to adopt whatever you guys have because I've seen it. I've seen it grow. I've seen it only get better. My whole philosophy is this is the worst it's going to be. My whole philosophy is this is not going to stop. So I'm bought into the changes.
Right. So it's effectively like, the quicker you are to adopt, the quicker you are to value, whether it's like revenue operation wise or patient care wise, right?
It's only helped. I haven't seen any negative. Like I said, we'll get patients that complain. Hey, I want to talk to a real person. I got a call from a patient over the weekend and I told them the call the office for an appointment. And I said, if you get an AI agent, go ahead and book the appointment anyway, and then text me back if it's not this week or something. So I adjust it. He texted me back and says, I love the agent. The agent was perfect. So the way, I don't want to stereotype across the board, but the more sophisticated the patient, the more adaptable they seem to be to the agent. Right. Whereas the people that are going to complain and are less innovative or progressive in their thought process, they're the ones that say, hey, I want to talk to a real person. That's all I can say, because I've only seen it help. It's helped me.
So you mentioned the op report scribe. Like, what else is in the vision of Dr. Ting for healthcare's future?
Everything. Okay. I mean, reports. I do med legal, and there's a thing called QME reports that we do when we evaluate. It has nothing to do with treatment, but you got to look at medical records. You got to look at past history, and you evaluate. AI has been phenomenal in that. It's been absolutely phenomenal. I used to have to dictate these 12-page reports. I no longer dictate. It's templated. I put in what facts are needed, and it's been phenomenal. And it's come up at meetings. You hear about these guys who talk about using AI for med-legal reports, medical record reviews. Unbelievable. It just keeps, like I said, it keeps growing. Right. In terms of what we're using it for. And then I see, in surgery, I use robotics. I use augmented AR for my knee replacements. You got to use the technology. It's there. Why would you not use it? You're more accurate. Okay. Faster. It's just changing your workflow technically. Okay. Like you have to register the knee now. When I first started using robotics, it actually takes a little bit longer, but once you get the workflow down, it's way more accurate.
Right. So I guess on the counterpoint, what's one thing you would change in U.S. healthcare outpatient care tomorrow if you could?
Reimbursement. Because I see healthcare getting devalued from the professional level, meaning the doctor level. As I said, we live in a capitalistic society. Okay. So your incentive is you should get paid more if you do more. Okay. Fee for service volume model. Okay. Here with the managed care model, you are managing a set pool of money to do certain things. So naturally, your incentive is to do less. Okay, because you only have a set pool of money to do everything for. It's like going to a buffet. You pay one food, you eat everything that's there. So the model where you're not incentivized to do more, healthcare becomes devalued. You want to do less. You don't want to get the tests. I mean, there's some abuse that got us into this, probably. But the bottom line, the one thing I've seen change, just an incentive of the people that work outpatient surgery center, the morale's down. The doctors are saying, if I was to do it over again, I wouldn't go into medicine. I can't concentrate on treatment. I'm charting, I'm doing all this other stuff that I have to do to get, and they're cutting the reimbursements. So it's gotten a bit negative.
Right. And, to that point, with healthcare being devalued, what is your personal why that keeps you going?
I keep doing this because I enjoy it. Yeah. I mean, waking up every day, going to a place where people want you to take care of them is a huge motivating factor for me just in itself. I don't even look at stopping. Plus, it makes me relevant. I'm doing something. If I wasn't doing this, what would I be doing? Nothing. Okay. So I appreciate patients coming in to see me. I relish that whole thing. You know, I wouldn't know what to do if I didn't do this. You know, this gives me some purpose every day.
Just some final words here from me and, the larger Camira Thalas company. You mean a lot to us here. We hope that we can continue to do the best for your practice and the actual care that you're giving your patients. So from us, your partnership means a lot. So thank you for that.
No, I appreciate you guys.
Amazing. All right. Well, thank you so much for being here today.